Uh, Tiptoe walker. So if I see a patient with a tiptoe walking, I would like to assess the patient, clinically examine him, take a pertinent history, and maybe sometimes I would need further examination with further tests. So history, examination, further investigations. Uh, Regarding my thought process, whenever I am seeing a patient with tiptoeing, can have multiple reasons. Either it can be because of it can be idiopathic, it can be cerebral palsy, it can be limb length discrepancy, it can be Duchenne or neuromuscular dystrophy, or it can be a tight Achilles cord. So as the causes are multifactorial and different forms, I would like to have a patient's developmental history, any problem while childbirth, any prenatal, perinatal, and postnatal complication which can have a predilection towards CP. In prenatal, I would like uh, to know any history of eclampsia, any history of oligohydramnias, any alcohol intake, or any complications during the prenatal period. In the perinatal period, I would like to know how the delivery happened. Was there any difficulty, or there was any obstruction? In the postnatal and in the prenatal, I also exclude the TORCH infections. In the postnatal, I would like to know any injury to the head region or any history of trauma in less than 2 years of age. Regarding the developmental milestones, I will assess the patient with respect to ambulation, when he starts sitting, when he starts walking, having meals, other playing with the kids, and whether there is any change in the attitude. Regarding clinical assessment, I need to check the patient with limb length discrepancy. I would like to examine the patient with respect to other joints being involved. I would check the silver scoid test to exclude if the tetanus is arising from the gastrocnemius itself or the tight cords. I will also examine the patient to exclude any neuromuscular diseases like Duchenne's or Becker's. I would like to ask the patient to squat and stand up and to exclude by Gower sign. If anyhow, my examination would help me to identify the cause, and then I will go for the treatment of the cause. If this patient is having good strength, um, good strength, and he's ambulant, and I have no stigmata of underlying problems, I can continue with the conservative measurements. Anyhow, if I have um, any signs which does show if there is any pathology, I would exclude that by further investigations. So for the CP, the diagnosis is clinical. For the neuromuscular disease or the Duchenne, I need to do further investigation with respect to creatine kinase, and also examine the patient and possibly for a muscle biopsy.